My name is Eisman. I'm a PGY1 in internal medicine as part of the physician scientist training pathway at Yale in cardiovascular medicine. And I'm excited to present today some work that I did as part of my graduate studies at Brown as part of the Center for Biomedical Informatics. In particular, I'll be presenting a paper we just published, Learning Health System Linchpins, Information Exchange, and a Common Data Model. As many of the people on this call know, learning health systems are envisioned as a dynamic, socio-technical solution that facilitates continuous healthcare delivery improvement. They require technology infrastructure to implement and have been described in many sources as comprising three phases. In particular, the transformation of raw data into knowledge, the application of that knowledge to change clinical practice, and then the capturing of clinical practice as raw data in a cycle. In our paper, we assert that the electronic health record is well positioned as the vehicle for capturing clinical performance as raw data. However, as we're all well aware, and is one of the primary reasons for OMOP in the first place, the mechanism for storing those records is incompletely standardized. And in addition, patients in the real world are seen at multiple health systems, certainly in the United States, and their healthcare data footprint is often scattered across multiple different EHRs, meaning that the data doesn't exist in one place for a particular patient. Health information exchange may be a solution for this data fragmentation problem and is the basis for our study. But first, I'm just going to go over some of the biological basis and background of the clinical application that we considered. Briefly, cardiovascular diseases are the leading cause of morbidity and mortality in the United States, and atherosclerosis is the primary mechanism for cardiovascular disease development. Atherosclerosis, in particular, is the gradual buildup of plaque on the intimal walls of arteries that results in the narrowing of the lumen, increased turbulence of blood flow, and increased risk of plaque rupture, resulting in downstream total arterial occlusion. When this occurs in the heart, it's a myocardial infarction, and in the brain, we call it a stroke. Complete elimination of blood flow for an extended period leads to cell death, secondary to lack of oxygen supply. And depending on the size of the affected tissue, this can result in irreversible heart failure, functional impairment, or death. The accumulation of plaque occurs over a lifetime, and it's common for older asymptomatic adults to have arteries in their heart that are more than 70% occluded. However, symptoms from ischemia only occur very late in this process. Longitudinal epidemiology studies going back 75 years have shown that exposure to risk factors over decades increases an individual's chance of major adverse cardiovascular events. And these include, but are not limited to, the person's age, their sex, elevated blood pressure over time, cholesterol, smoking, diabetes, and family history. Some of these risk factors, including blood pressure and cholesterol, are modifiable using pharmacotherapy and have informed guidelines for treating risk factors with drugs as a means of primary prevention. Guidelines for lowering cholesterol with statins in individuals without known existing cardiovascular disease rely on the predicted risk of incident myocardial infarction or stroke over the next 10 years. And in particular, individuals aged 40 to 79 with either intermediate or high risk of incident event over the next 10 years should be on statin therapy to lower their cholesterol, stable plaques, as a means of primary prevention of heart attack and stroke. And so for this study, we considered the estimation of 10-year cardiovascular risk and statin guideline adherence in the context of fragmented health data across the state of Rhode Island using data curated from our health information exchange. In order to accomplish this, we set out to transform our statewide health information exchange to the OMOP Common Data Model and term this transformation of our data warehouse an HICDM, or Health Information Exchange Common Data Model. This study demonstrates the utility of centrally managed HICDM to facilitate data flow from performance to knowledge, thereby breaking down the barriers of transitions in the learning cycle. We examined the scope of this data fragmentation problem, identified population health trends, and the potential for performance enhancing knowledge through the lens of atherosclerotic cardiovascular disease. In particular, we hypothesized that individuals in Rhode Island have pharmacotherapy determining risk factors regularly measured at multiple healthcare institutions, and that ASCVD risk factors, 10-year ASCVD risk, and primary prevention practices differ by primary care institution type. In Rhode Island, our HIE aggregates more than 102 million patient care transactions, including more than 90% of prescription fill data, 90% of laboratory data across over 400 sites and 520 distinct sources of data for over half the state's population. We use standard Odyssey tools that Matilda really detailed really well just in the last presentation. And I'll gloss over some of those details to do our mapping. In particular, the bulk of our mapping was done with the Odyssey source to standard SQL queries, which converted more than 99% of our HIE data warehouse data points from our origin problems, diagnoses, drugs, and observation tables. In particular, our problems and diagnoses were separated into two different tables, but then they get translated into a single condition table in OMOP. Our measurement table required significant manual mapping. 15% of data points were in free text formats, and we used Usagi to transform the 1,000 most common phrases to standard LOINC codes. We found that most of our unmapped codes were either unintelligible or non-specific data points, for example, test performed or other things that didn't really lead to any meaningful data loss. Of note, our source data separates diagnosis and problems, as I mentioned, and then gets mapped into a single condition table. So our source problems were in SNOMED format, and then our diagnoses were in ICD-9 versus and ICD-10, depending on when they were from. For our case study, we applied a set of inclusion criteria for our cohort for estimating 10-year ASCVD risk that was informed by guidelines. In particular, we required that we had the data necessary to calculate risk, which includes having a systolic blood pressure measurement, cholesterol labs, and that they were age 40 to 75 years old without evidence of prior ASCVD events in their clinical record. One metric that we were particularly interested in looking at in terms of what would result from transforming our data into OMOP was that of dimensionality reduction. And here's an example of how there are 5 common codes for dyspnea or shortness of breath in our HIE data warehouse, all that map to a single SNOMED code. And this greatly simplifies the process of using these data going forward. Looked across vocabulary domain, it's clear that these many-to-one relationships are common, and they're particularly common for conditions and drugs. Viewed another way, the number of most common codes that you would need in order to have good coverage of a particular source concept to standardized concept can be quite high, and that's particularly true in the observation domain and also in the drug domains. With our HIE, CDM, and OMOP format, we then were able to calculate 10-year risk for our population over time and classify them into guideline-based categories. As a reminder, those individuals at intermediate and high risk that in orange and red on this graph are supposed to be on statins for primary prevention. So most of them should be taking statins daily based on guidelines. Underlying that data, in aggregate, are individual trajectories for patients. For example, here's a 55-year-old woman who smokes tobacco, and early on in her trajectory, she's at low to intermediate risk. And over time, based on increasing cholesterol and blood pressure, her risk goes up. And she's not on a statin through this whole time. When she's in orange, she should probably be on a statin for primary prevention until in the middle of 2018, she has a myocardial infarction and then goes on a statin for secondary prevention. At the bottom of the graph, you can see where the data updates came from, and they came from 3 different sites in her case. And in particular, she has cholesterol measured at 2 different locations and blood pressure measured at 2 different locations. Based on my own experience, these would not be easily or readily accessible quickly from an individual electronic health record. So these data are unlikely to be all taken into account when making a decision for this patient. We next asked how well individual adherence was according to statin guidelines. based on looking at their days spent at different risk levels and whether someone was on a statin at the time. We found that individuals at intermediate and high risk were more likely to be on statins, but there's still a significant number of days. In fact, more than half their days spent at intermediate and high risk as a population, patients are not on statins in Rhode Island. Finally, we considered possible disparities, and we looked at health systems. Those are the large health systems in the state, and compared them to federally qualified health centers, which are known to treat un- and underinsured individuals that are higher risk. In particular, the demographics at the federally qualified health centers, the patients are younger, more likely to be female, and more likely to identify as Black or African American. These individuals had unfavorable risk factors after adjusting for age and sex, including higher blood pressure, higher cholesterol, more likely to have diabetes and use tobacco. And at the intersection of race and ethnicity, we had noticed that patients at these centers had unfavorable adjusted risk factors. However, we did find that while they were more likely to be at high risk and spend more days at intermediate and high risk compared to patients at health systems, they were also more likely to be on guideline-directed statin therapy, indicating they were getting the treatment that they were indicated for. In summary, through the creation of our HIE-CDM, we're able to identify individuals who should start guideline-based primary prevention with statins. For example, a 62-year-old female smoker with elevated cholesterol and high blood pressure should be on statin therapy. We're also able to look at health equity measures and see, for example, at a large FQHC that both men and women with diabetes, both who should be on a statin, are equally likely to be on statins. And finally, we can identify high-risk populations. And so, for example, in 2022, we were able to see that 45% of myocardial infarctions and strokes in our population occurred in patients who were identified previously to be at high risk and not currently on a statin. I want to just acknowledge and thank all my co-authors with which this work would not be possible: Elizabeth Chen, Hank Wu, Karen Crowley, Dylan Mathuj, Katie Brown, and Neil Sarkar, and also our funding sources. Thank you for listening, and feel free to reach me at my email.